So the valve clinic was developed with the idea that when patients have valve disease, they need to see multiple different people and get multiple types of testing. We have patients that are coming from 3, 4, 5 hours away, and to have them come back for multiple visits is very difficult on families. So we wanted a one-stop shopping, kind of easy button for valve disease. So patients would come in, they'd see myself in the morning. I'd decide what they have, how severe is it, and kind of what needs to be done. Additional testing is then done kind of during the day. If they need a surgical opinion, they see the surgeon on the same day in the afternoon. We have a plan all within one day, so it is a long day of testing and appointments, but that prevents patients from having to come back multiple times.
This is a practice one, so let's give that a good squeeze.
I think the real benefit of the clinic is the multi-specialty evaluation. A lot of these patients would see a cardiologist, have to wait 2 weeks to see the cardiac surgeon. This interaction between the cardiologist and the cardiac surgeon happens immediately after the patient is seen, and a discussion ensues that allows them to make a comprehensive plan of care for the patient.
Do a TE in 2 weeks and then bring her back. And I think it's much safer to do it. That's how they do it there. So in the past, when a patient was admitted for a chronic disease, often the care was very disjointed. You'd have a separate primary care doctor, you'd have a separate cardiologist, you'd have a separate social worker. You often didn't have discussions about end-of-life care or palliative care, okay? So having a chronic disease management setting under one roof where they have different providers being able to weigh in and participate and having a quarterback to kind of get all these resources available is very important. Mitral valve, and then the tricuspid valve is on this side.
Ideally, we sit down with an anesthesiologist, a cardiac anesthesiologist. We sit down with a cardiac surgeon. We sit down with a valve clinic physician whose specialty is only valves, as well as our valve clinic coordinator, and we go through all the details of the patient. The characteristics of that single individual patient that makes them either high risk for one procedure or lower risk for another procedure. And then our attempt as a collegial group is to decide the best method to take care of the patient's disease.
Are you a smoker?
No.
And the complex valvular patient that a lot of doctors didn't have options for, there are options now. And so as we get the word out, we're going to a lot of the primary care physicians telling them that this clinic is available. They can refer patients here, have them evaluated, and then sometimes the decision is left to the primary care doctor. What do you think? You know this patient best.
When the patient sees me in clinic and I refer them to surgical evaluation, Dr. Akins or Dr. Talbot will decide the risks and benefits of different types of procedures.
How tough was your first surgery? Pretty tough, right?
One of the procedures we have is a minimally invasive procedure. So instead of doing traditional open heart surgery through the entire chest wall, which has a longer course of recovery, they can make smaller 2-inch incisions to the side here or underneath the breast so that they can access the valve that way. Patients tend to recover quicker, they get off the ventilator faster, they go home sooner, and their overall recovery time is shorter. We have a new option available for patients with aortic valve disease where we can actually go in through the groin like a heart catheterization and replace the valve through the groin. So for the high-risk patients who aren't a surgical candidate, who in the past would be referred home to slowly die from heart failure or have sudden death, we can now replace their valve through the groin.
Any patient with valvular disease can be referred to the clinic. We would prefer them to have an echo because that's the main test that allows us to look at their valve. Most of the physicians currently are referring complex valvular patients to us, and the most common two valvular diseases we see are aortic stenosis and mitral regurgitation, and that's just because they hit a big portion of the population.
That's the question. That's what you want to know.
This is the model that I think is going to be used more and more often for things like chronic obstructive pulmonary disease, like emphysema, for heart failure management, for diabetes, because frankly it works.
McLaren Northern Michigan. Expect the best.